Good afternoon. Thank you for joining us today for the Therapy Partners and Solutions session. My name is Debbie Schofield and I will be moderating this session. I am going to begin by providing an overview of gynecologic HDR. We will then have 3 great presentations from our partners in solutions as they discuss their GYN HDR products. Peter Morsink from Elekta will present first, followed by Luke Chan from Zoft, and then we will finish with Sophie Weatherall from Varian. For full disclosure, my clinic is a clinical HDR training site for Elekta, and I am a physics instructor for the course. We are going to start with a high-level review of gynecologic cancers, including both the global and national incidence of the disease. We will then move on to review the role of brachytherapy in the treatment of GYN cancers. Following an overview of GYN HDR applicators, we will review the move from point-based planning methodologies to IGBT, or image-guided brachytherapy, and discuss some key items to consider. Finally, we will finish up with a brief review of the commissioning process of any new applicator. The phrase gynecologic cancer is an umbrella term covering half a dozen cancers of the female reproductive system. These include cancers of the vagina, vulva, cervix, uterus, fallopian tubes, and ovaries. This image from the CDC shows the relative position of these cancers. Fallopian tube and ovarian cancers are generally not treated with brachytherapy. Cervical, uterine, and vaginal cancers are the most common gynecologic cancers treated with brachy, partially due to their location and the ability to use intracavitary placement of applicators for their treatment. Globally, gynecologic cancers occupy positions as the 3rd, 6th, and 8th most common cancers amongst women. Over 500,000 cases of cervix uteri are diagnosed annually, while almost 400,000 and 300,000 cases of corpus uteri and ovarian cancer are diagnosed each year, respectively. These 3 gynecologic cancers are responsible for approximately 1.25 million cancer diagnoses in women annually, which is a considerable global health burden. In the U.S., almost 100,000 women are diagnosed with a gynecologic cancer on an annual basis. In the United States, researchers utilize the Surveillance, Epidemiology, and End Results, or SEER database, to review trends in the use of brachytherapy in the treatment of cervical cancer. A matched cohort of over 3,000 patients treated between 2000 and 2009 with a median follow-up of 3.4 years were identified. The 4-year overall survival for patients treated with brachytherapy in addition to external beam was higher than for those treated with external beam alone. The brachytherapy cohort has a 4-year overall survival of 58% versus 46% for those patients in the non-brachy cohort, which was significant at the p less than 0.001 level. Interestingly, the researchers also plotted brachytherapy usage in the treatment of cervical cancer between the years of 1988 and 2009. Despite brachytherapy having a significant impact on survival, its usage declined from 83% in 1988 to just 58% in 2009. In this work, Gill et al. Utilized the National Cancer Database to evaluate brachytherapy boost treatments versus IMRT or SBRT boosts in cervical cancer patients. Reviewing data from 7,654 individuals, the researchers found that the median overall survival for those who received a brachytherapy boost was 70.9 months, while those who received an IMRT or SBRT boost had a median overall survival of just 23.8 months. That's a 47-month survival disadvantage for those who did not receive a brachytherapy boost. Interestingly, despite the disadvantage of SBRT or IMRT as a boost technique, its use increased as a function of time, while the utilization of brachytherapy as a boost fell. In addition to brachytherapy providing an advantage for many women diagnosed with gynecologic cancers, another study found that the total treatment time significantly impacted outcomes as well. Overall, the researchers found that treatment time should be kept to less than or equal to approximately 52 days, or roughly 7 to 8 weeks. Loss of local control and overall survival decreases by just about 1% per day for each day that treatment extends beyond this time frame. Overall treatment time is a highly significant factor affecting treatment outcomes. So now we know that brachytherapy plays an important role in the treatment of gynecologic cancers. What is our current practice and how did we get here? Let's take a look at the evolution of brachytherapy and how we arrived at our current practices. In the 1920s, standardized systems were in use, such as the Stockholm, Manchester, and Paris systems. These all used standardized loading patterns expressed in milligram radium hours. Treatment times, unlike what we know now, was on the order of days, sometimes as much as 5 days, as opposed to mere minutes. In the 1950s, we see the beginning movements towards customization. Points A and B were introduced. While the definition of where they were located has changed a bit over time, points A and B are surrogates for the cervical target and the obturator lymph nodes, respectively. While it was a movement away from standardized systems, we still see that we're not planning to the exact disease extent for each patient. In the 1980s, ICRU 38 was published. It suggested that a new reporting system was needed. During this time frame, we also see the introduction of high dose rate and pulse dose rate systems, as well as the introduction of some of the first brachytherapy treatment planning systems. By the 2000s, we see the use of low dose rate systems diminishing and the use of high dose rate systems increasing. This was certainly beneficial for the patient as it shortened the treatment time and in most cases eliminated overnight hospital stays. We also see an improvement in our treatment planning systems as they become more sophisticated. We also saw a further move away from using standardized systems and the use of a more customized treatment approach. The similar situation was seen in the same time frame in external beam. Instead of using standardized systems such as in this 3-field head and neck technique, we see the increase of imaging and customization through IMRT, for example. So this same evolution was happening in brachytherapy. There are many different applicators used in brachytherapy, including a wide variety used specifically for gynecologic HDR. Why do we need so many different applicators? Why isn't a one-size-fits-all, or at least most? This is a cervical cancer staging atlas. If we start on the left, the small gray mass at the level of the cervix represents the tumor. It's fairly small and regular. But as we start scrolling across to the right, we can see that the gray mass morphs. Not only can it increase in size, but it can also increase in spread. Even a 2B mass is showing lateral infiltration despite having a fairly small central cervical mass. The 3B shows an even larger central mass and further lateral infiltration, while the 4 and 4A show extensive disease. By just looking at the variation in the tumor, both in size and spread, we can see that one device alone typically won't work for all of these scenarios. And this is all within a single disease family. Within gynecologic cancers, we have additional disease families that we may need to treat as well. As a result, anyone with a fairly broad gynecologic oncology practice will typically need a number of applicators in order to treat the wide array of gynecologic cancers that they may see. Vaginal cuff brachytherapy is one of the most common gynecologic cancer treatments, and the vaginal cylinder is the most commonly used applicator for this purpose. The vaginal cylinder is an intercavitary treatment and is typically done on an outpatient basis without anesthesia. Patients are awake for the treatment, although a lidocaine or other topical treatment may be applied to reduce discomfort. A single-channel vaginal cylinder is shown on the left. The cylinders come in a variety of widths to accommodate different patients. The largest diameter cylinder that can comfortably be accommodated should be used. With a single channel, the dose distribution is spread evenly in all directions. This limits how much OAR sparing can be allowed, while also treating the necessary volume. A multi-channel vaginal cylinder is shown on the right. In addition to the central tandem, there are a number of channels located around the periphery of the device. This allows for more dose shaping, particularly if an irregular pattern is required. As shown in the isodose distribution on the right, the red line, which is the 100% isodose line, is much tighter on the posterior aspect, but the dose flares out laterally. This provides enhanced rectal sparing. For treatment of the cervix, a tandem and ovoid, shown on the upper left, or a tandem and ring, shown on the bottom left, are often used. The ovoids or the ring are placed against the cervix, while the tandem is inserted into the intact uterus. The rings and ovoids come in several sizes and angles. The tandems also come in different lengths and angles. This allows for the best fit to be selected to provide the most optimal dose distribution for the patient. In both images, a rectal paddle is displayed. This device helps to push the anterior rectal wall further away from the treatment area and reduce the dose to the rectum. With or without the use of the rectal paddle, vaginal packing is added to help stabilize the device and prevent movement of the applicator, especially during patient transport, such as during imaging. Packing also helps to further push the OARs away from the device. Patients are often placed under sedation during the insertion process. However, the explant can take place without sedation. Both of these devices can produce the classic pear shape, as seen in the upper right-hand corner. The classic pear is achieved with about 80% of the dose being delivered through the tandem, and the remaining 20% delivered through the ovoids or the ring. While the devices are fairly interchangeable, the TNR does tend to give a narrower dose distribution. On the bottom right-hand corner, you see a modified pear, and that's where you're changing that dose distribution in order to provide a more patient-specific treatment. This is an example of an interstitial applicator. The purple template is sutured in place and is used to guide the needle for an interstitial implant. These implants can be used to treat a number of gynecologic cancers, such as cervical, vaginal, and uterine, particularly if they are more advanced. Given the large number of potential tracks, the needle placement can be customized for the patient. Patients are generally sedated for both the implant and the explant. At our center, we typically treat these patients BID or twice a day due to the invasive nature of the procedure, which allows for fewer implants overall. There are some patients who may benefit from a hybrid applicator. This type of applicator is a cross between a TNR or a TNO and a full interstitial implant. For example, a woman with a larger cervical cancer, whether that's in size or in the spread of the disease, but not extensive enough to warrant a true interstitial implant, may benefit from the use of a hybrid applicator. In this retro-embrace study, 610 patients were evaluated and broken down into patients that received brachytherapy using only an intracavitary device, such as a TNO or a TNR, and compared to those who received brachytherapy using a hybrid applicator. For patients with a smaller tumor volume, defined as less than 30 cc's, there is no difference between the two groups, and that's not entirely surprising. But for patients with a larger tumor volume, defined as greater than or equal to 30 cc's, there is a significant difference between the two groups, with those in the hybrid group experiencing a significantly higher level of control. It is also interesting to note that in both the larger and the smaller target groups, there was no statistically significant difference in the OAR doses. This provides some evidence that a hybrid applicator is appropriate for some women. While we have hybrid applicators and image-guided brachytherapy that allows us to better shape the dose, the creation of a homogeneous dose distribution may not be desirable. In this example, we have similar coverage on the target volume, but the 150% isodose line is different between the two plans. These central hotspots created by a single tandem is likely still largely desired. It is these large hotspots created in brachytherapy plans that may be linked to local control. Point A has been used for many decades as a way to define dose to the target. The definition for defining the location of point A has undergone some changes over the years. The current definition is based on applicator geometry. Since it is based on applicator geometry, 3D imaging is not required for this type of planning. This makes it widely accessible since planar X-rays can be utilized. It also can be a very efficient system because there is little to no contouring that's required, particularly if just using planar images. While point A is tied to historical clinical outcomes, planning based solely on point A lacks using input from modern imaging to influence the resulting dose distribution and target definition. This could potentially lead to the underdosing of a tumor volume or the overdosing of surrounding OARs. It is also susceptible to subtle differences in applicator geometry. More recently, image-guided brachytherapy has become more prevalent. In order to perform image-guided brachytherapy, 3D images are required. The 3D images allows us to perform a patient-specific definition of the target volume as well as the OARs. Depending on the imaging that is used, that means the differentiation between uterus, periuterine, and tumor tissue may be possible. Image-guided brachytherapy also allows for the potential for dose escalation, which we will see an example of shortly. Just as with external beam radiation therapy, image-guided brachytherapy has its drawbacks, including our reliance on the accuracy of contouring for optimal results. We see the same thing in IMRT. As we are better able to sculpt doses, the accuracies of the contours become of vital importance. Because accurate contouring is a requirement, it also makes image-guided brachytherapy less efficient than the point A methodology. And as with anything new, there may be a learning curve. In this example from Vargo et al., we see a comparison of the point A and the IGBT methodologies. On the top row, our isodoses are defined via point A. The red line, as indicated by the arrow, is our 100% line, and we can see that we have plenty of coverage of our actual target volume. The downside to that, as you can see in the above right image, is that our sigmoid is getting a very large dose. On the bottom row, we're using the same target volume, but we're tweaking our isodose distributions based on the actual disease of the patient. The red 100% isodose line is much tighter to the volume, which also results in sparing of the sigmoid, as seen in the bottom right-hand corner. Conversely, we could see how the same could be true if we were to use point A and it was a larger target volume. We would end up underdosing the target. This is an example from our clinic where we utilized a simultaneous integrated boost type image-guided brachytherapy technique. The larger high-risk CTV, or HRCTV, is shown in light pink. 97% of that volume is receiving the 600 centigrade dose prescribed. However, we were also able to identify a GTV and manipulate the dwell times to produce a hotspot in the region of the GTV. 90% of this GTV received 920 centigrade. We should also note that we were able to respect all of our OAR dose constraints. There are several society-level recommendations regarding the use of image-guided brachytherapy. The American Brachytherapy Society recommendations for cervical cancer include acquiring a CT or MR and planning at every insertion. In 2012, Jack Estro also came out with recommendations. They recommend getting an MRI prior to treatment to be able to better visualize the target extent. They also recommend acquiring an MRI for the first brachytherapy treatment with the applicator in place to better define the HRCTV. They also specifically recommend the use of T2 images. In 2016, ICRU 89 was published. This defined MRI as the gold standard to be used to assess gynecologic tumors. ICRU 89 also outlined an extensive 3-tier dose reporting structure. The first tier is the minimal reporting guideline, including tracking the point A dose, which again is tied to historical outcomes, while the third tier is more designed for research purposes. So we have multiple societies recommending the use of 3D imaging with a definite tilt towards MRI. CT imaging does have some pros, including the fact that you don't need special MRI-compatible HDR applicators. Reconstruction is also simple, as the catheters are easy to visualize, which helps speed up the reconstruction timeline. Since a CT scan is acquired quickly, there is less chance of artifacts due to patient motion. While CT has many benefits, there are some disadvantages. Some clinics may need to move patients in order to acquire a scan, and CT does not have great soft tissue differentiation properties. MRI's biggest pro is the image quality and the excellent soft tissue differentiation. However, there are some downsides. Many clinics don't have an MRI in-house, which can make scheduling difficult and will often include the need to move the patient. Longer scan times may lead to increased artifact due to patient motion. There are also patient size and clearance issues. MRI-compatible dummies and applicators are necessary, and catheters can be more difficult to see and reconstruct. Susceptibility distortions become a bigger issue as they impact geometric accuracy. Guidelines from Jack Estro, however, suggest that the susceptibility artifacts for field strengths of 3T or less are generally still within reason. In this example, the HRCTV is outlined in light pink. Based on the CT alone, it is difficult to differentiate tissue and clearly identify what should be marked as HRCTV. On the MRI, however, the HRCTV becomes much more visible as we are able to differentiate between tumor and surrounding normal tissue. While the MRI clearly shows us improved visualization of the tumor, identification of the catheters is much more difficult. On the left-hand side of the MRI image One could almost believe there are 3 additional catheters. However, the CT on the left provides better ground truth and demonstrates no catheters in this region. While these MRI images are actually from an HDR prostate patient treated in my clinic, they very nicely demonstrate the issue. On the left-hand side is an MRI with little artifact due to patient motion. The catheters are relatively easily identifiable. On the right-hand side is an MRI with patient motion artifact. The catheters become very difficult to identify. Because of the longer scan times on an MRI unit, these patient motion artifacts can become an issue. This is a case from our clinic where we used a Venezia hybrid applicator on the same patient on multiple fractions. In this first image, we see a small void in the MRI at the level of the ovoids, but we can clearly see the needle tracks above and below this small void. On this particular day, the patient bled a bit more, which ended up actually saturating the packing, which is that bright white area in between those 2 catheters. And it actually helped to enhance the tracks for our reconstruction. This is an MRI image for the same patient on the subsequent fraction. In this particular day, there was less bleeding, and as a result, the catheters could not be identified or reconstructed based on the MRI alone. The importance of commissioning the applicators before use cannot be overstated. Robust testing should also be performed when moving from CT to MRI-based planning. Variations between the 2 can exist due to differences in the marker used, susceptibility artifacts, etc. Visual inspection of all parts and components should take place, as well as radiographic inspection of all parts to look for cracks. Commissioning of dummy markers and all components with the dummy markers should also be conducted. Validating lengths and running test plans should be included, and policies and procedures should be developed, including both planning and treatment policies and procedures. In summary, brachytherapy plays a critical role in the treatment of many gynecologic cancers. There is variations in the disease presentation, and that will dictate the need for a variety of applicators. While Point A provides historic dosing information, there is a need to move to image-guided brachytherapy treatment to provide a more customized treatment to these patients. And robust applicator commissioning must be conducted to ensure safe treatments.